All righty. Well, good morning, everyone. Nice to have you here with us. This is our monthly webinar, which we do, it's always the third Friday of the month. And it's something that we started, it used to be a live networking event, and then we morphed it, in COVID over to a webinar. And so now we're able to get people from other parts of the country to join us, which is always fun too. So if you're here in the Chicagoland area, it's a beautiful sunny day, and I hope wherever you are, that's the case too. So thank you to Nat and to Ingrid, who are our producers here, and an enormous thank you to Dr. Richard Shapiro for joining us today. I'll do your intro in a moment, but Richard was such a good egg. Somebody called him on vacation and said, hey, can you do a webinar for us? Didn't really give him all the information of what this was going to be. So I think it's going to be amazing. Richard is an absolutely lovely human being, a fabulous psychiatrist, and just a really good guy. So let me tell you a little bit about Dr. Richard Shapiro. He is works with us currently. I'm so grateful for that. He is a graduate. Dr. Shapiro is a graduate of Harvard College and Cornell University Medical School. After completing his residency training at Harvard Medical School and Cambridge Hospital, he practiced general psychiatry in Boston and the San Francisco Bay Area. Lovely. He has specialized in medical management and treatment of mood and anxiety disorders and the diagnosis and care of adults and adolescents living with chronic mental illness. Dr. Shapiro has been board certified in both adult and forensic psychiatry by the American Board of Psychiatry and Neurology, as well as serving on the teaching faculty of Harvard and Stanford medical schools. He was also the chief psychiatrist of the Center for Survivors of Torture in San Jose, California. I mean, it just kind of goes on and on. Really, just such great history. Dr. Shapiro has researched treatment of OCD and published his findings on the results on eye tracking studies in the field. He has presented on schizophrenia as well as OCD at the American Psychiatric Association, a pioneer in the field of repetitive transcranial magnetic stimulation. Dr. Shapiro was the founder of the Golden Gate TMS. He has extensive clinical experience in the field of TMS and has been educating the medical community on its use for treatment of mental illness. And maybe someday, Richard, will have you come back and give you a little more notice and have you talk about that. So I love reading all of that. You have such a great background. So appreciative. Thank you for being here today talking about bipolar disorders, diagnosis, medical treatment, and expected outcomes.
Well, thank you, Margot. That was a very nice introduction. I appreciate it.
Start with me. We'll just have at it.
Okay. So I'm kind of trying to gear this talk towards clinical perspectives on bipolar disorder. I don't want it to be heavy on research. I'm not looking to give a psychopharmacology seminar. So I made these slides to just stimulate conversation, and that's what I'm hoping we can do. I don't want to just read the slides, and I'm hoping that people will send their questions, points of interest, observations. Margot is going to be the moderator, so she'll read out things that go into the chat. So feel free to post in the chat, and we will do it in real time. So, you don't have to wait to the end. If you have a question or something you want clarified, please just send it in, and Margot will be the traffic officer on that.
I will be the traffic. And yeah. I'm so sorry to butt in here, but I think this is perfect timing. If we can do just a little bit of housekeeping, and then we will get
absolutely
moving.
Perfect. Good morning, everyone. So like Dr. Shapiro mentioned, if you do have a question, please use the Q&A option that you have on your screen. For the chat purposes will be for technical problems. So if you do have a question on any technical issues that you are having, please use the chat. If you do have a question for Dr. Shapiro, please use the Q&A and we will answer those questions live. For those of you who have the paid version of the CEU, afterwards you'll log into the CEU online school. To access the course, you will complete the end of the session test and evaluation. for you to receive your certificate of completion. You will be able to view it and download it and just have access to that. We will also send an email to everyone outlining the steps immediately after the webinar so that you have instructions on how to access your CEU afterwards. All right, thank you so much.
Wonderful. All right, Richard, we're going to let you,
Okay.
but folks, this is a conversation today. So throw your questions into that Q&A anytime.
Okay, well, let's just start with the title of the talk. I put that together very quickly. I'm hoping to hit most of these topics, and I'm happy to elaborate if people have more questions. To just remind people, or to start off with, I just want people to know that I have no conflict of interest. I'm not promoting any medication, and you're hopefully receiving objective information from me based on my clinical experience. To get back to what were the posted objectives of the talk, I'm hoping that people will learn why your clients are prescribed so many medications for bipolar disorder. And what I mean by that is not just that people are on many different medications, but they're also on many different combinations of medication. And that can be confusing, especially in this time when there are so many articles, like recently in the New York Times, about polypharmacy in psychiatry, and does it make sense? So I'll try to touch on that a little bit in this talk. The next objective is to have people come to know why antidepressants should almost never be prescribed for patients with bipolar disorder. And we'll talk a bit more about that later, but I think the reason that I wanted to point this out is because, as you'll see later in the talk, people with bipolar disorder are mostly depressed. They're not manic or hypomanic. Or they're euthymic. And, when someone looks depressed and they're diagnosed with bipolar disorder, the immediate thought is, why not use an antidepressant? And we'll discuss that a little bit more about why antidepressants should be avoided if possible. And then the last objective is to learn how to work more efficiently and effectively with your prescriber towards a better treatment outcome for your client. So we will talk about that. I have a slide on that, but I'm happy to talk about that throughout the talk if people have questions. Okay, so this is probably a review for everyone, but it's very helpful to kind of remind ourselves of what the diagnostic criteria are for bipolar disorder and the different types of bipolar disorder. And why that's important is because for many reasons. One is so that we can all be on the same page. Research studies are done based on specific diagnostic criteria, and treatments are based on diagnostic criteria. So to begin with, I want to review what the symptoms are of bipolar disorder. And the symptoms that we're going to be looking for are inflated self-esteem and grandiosity. That's pretty obvious. Decreased need for sleep, increased talkativeness, pressured speech, and racing thoughts, easily distracted. And when I mention that one, it jumps out to me that that could be confused with many other diagnoses. Easily distracted could be ADHD. I just wanted to use this as a moment to talk about the differential diagnosis for bipolar disorder, because we're going to see things in our clinical practice that look like bipolar disorder, but might not be. So we have to keep these other differential in mind, things like anxiety disorders like GAD, panic disorder, PTSD, substance abuse disorders, and that